Hello, my name is Tara Austin, and I am a researcher and neuropsychologist at the VA San Diego healthcare system. And today I'm going to be talking about social determinants of health and their relationship to brain health. So today will be part one of two parts. So this first part will start by going over some brief definitions, talking about social determinants of health and examples of these, and then applying this information to the COVID-19 pandemic, which has been called the inequality virus due to the changes in social determinants of health. So to start with some brief definitions, health equity and health disparities. So health disparities are preventable differences in healthcare outcomes faced by disadvantaged groups with different burdens of disease, injury, or violence, or lack of opportunities to achieve optimal health. Health disparities are a result from uneven and unfair distribution of social resources. And then on the other side, health equity is the lack of health disparities or the absence of avoidable or remediable differences among groups of people, whether those groups are defined socially, economically, demographically, or geographically. And in all countries, we see a similar pattern of health and illness, that the lower someone is in socioeconomic position, the worse their health outcomes are. This is particularly important to neuropsychology, as racial and economic related health disparities are associated with increased risk of neurological illness and worse outcomes, as well as increased risk of cognitive impairment. So some more definitions. Poverty refers to not having enough money to meet basic needs, including food, clothing, and shelter. This is sometimes described in more relative terms. And there also are descriptions with discrete numbers. So extreme poverty is defined as a family living on less than $2.15 a day. Related to these, learning poverty is a lack of opportunity, and learning refers to an inability to read and understand a simple text by age 10. We have food deserts, which are geographical areas with limited or no access to affordable, healthy food options, particularly produce, due to a lack of grocery stores or places to be able to get those items. Healthcare deserts are similar, so a geographical area with limited resource, but in this case, it is limited or no access to healthcare services. Similar with technology, again, a geographical area with limited resources, and in this case, it's a higher than average number of households that do not have access to either computers or the internet or both. So it is a major goal of multiple international groups, including the World Health Organization, to increase health equity and to promote health and well-being across all ages. Physician, epidemiologist, and researcher, Dr. Lisa Cooper, described that to get from disparity to equity, our goal, we need to understand the contributing factors to disparities, such as social determinants of health. So these will be what we focus on today. Social determinants of health are non-medical factors that influence our health outcomes. These are the conditions in which we live, where we're born, where we grow, where we work, where we age, and also the forces and systems that shape our condition of daily life. This includes political systems, social policies, and economic systems. And these factors are really important because social determinants of health affect up to half of our health outcomes. And you can see in this graphic, when we combined several of these social determinants of health that we'll talk about, they often account for more of the variance, or they account for more of the relationship in outcomes than some of these health behaviors. So there was an incredibly powerful ad campaign based on research that examined the relationship of some of the social determinants of health to a very important marker of health, life expectancy. So they found that your zip code is the greatest predictor of life expectancy. So not blood pressure, not any of your physical health markers, but zip code. So variables such as housing prices, income, and education level all impact communities. People in communities with little or no access to preventative health care, healthy food options, safe parks, and good schools die on average 15 years earlier than those who have access. You can see pretty stark disparities, 55 years here versus 80 years. And there are multiple cities where 30-year differences in life expectancy occur in areas that are less than 1 mile apart. We're going to talk about an example of this. So in Dallas, Texas, near where my family lives, life expectancy for men in this green zip code is 90.1 years. And then about 2 miles away in zip code 25219, life expectancy is 63.6 years. So this is more than a 26-year difference due to social determinants of health. So what are these factors that are contributing to this health disparity in this example? The first is economic stability. Economic stability includes employment, stability of employment, as well as income, poverty, expenses, debt, and medical bills, and food insecurity. So we can see in this example, between these two areas, a pretty stark difference in income, with the area that has a higher life expectancy has almost twice the median income and half of the unemployment rate. The next social determinant of health is education, access, and quality. So access to programs such as early childhood development and education, higher education, secondary school, vocational training. And then this contributes to literacy and learning poverty when you do not have access to those services. And then quality of education is also important. So there are often differences in number of credentialed teachers or the preparation teachers have to be able to teach students. Student to teacher ratios. Additionally, education materials are the items needed to learn within the schools. So these numbers are pretty small, but you can see that in this area on top has the lower life expectancy compared to this area on the bottom with the higher life expectancy. So mathematic proficiency is 19% versus 85%. In reading proficiency, 22% versus 97%. So this will often reflect a difference in resources and opportunities to learn between these two communities that then contribute to the disparities in longevity. The next social determinant of health we are going to talk about is healthcare access. And again, quality is also important. Access includes ability to access services. So health insurance. Does someone have health insurance? Are they able to get that? What are out-of-pocket medical expenses, and are those possible within the budget? Also, things such as provider ability. Are there physicians or physical therapists or dentists or pharmacists within the area? There are communities that lack access to healthcare providers or lack access to specialty healthcare providers. And then quality is also important. So provider linguistic and cultural competency. Are you able to see someone who is able to contextualize your experience in a way that is helpful and meaningful to you and able to understand you? What are patient-provider ratios? What are your wait times? How long are your commutes? And are you treated with the highest standard of care? Is there even ability or resources to be able to provide that high level or standard of care? And here we can see some disparities between these two communities and in how easy it is to even get to the hospital. So both communities are close to major metropolitan large hospitals. However, in our community with the higher life expectancy, it's logistically much easier to get to the hospital. So there's a hospital within the community that takes 2-minute drive, 12 minutes public transportation, just one bus, quick was needed, came often. And then in our community where we see lower life expectancy, it was a much more difficult journey to get to the hospital, particularly if someone did not have a car to drive and relied on public transportation, which could take 48 to 60 minutes, involved transferring buses, transferring areas, as well as a half-mile commute between the last stop and the hospital. This would clearly be very difficult for someone needing emergent health care. Our next social determinant of health is neighborhood and built environment. This refers to stable, safe, quality, affordable housing. Again, that access to public transportation. How walkable is this area? Access to grocery stores, or is this in a food desert or a technology desert, as well as green space, parks, and playgrounds, which improve or are associated with better cardiovascular health and better overall health. Just having that green space, being able to be outside and feeling safe that you can be outside. So in this map, these green areas refer to healthcare deserts, and this blue one indicates access to food, especially the produce, fresh fruits and vegetables that we know are helpful for our health. And in our community that is experiencing lower life expectancy, they're pretty much surrounded by a food desert versus this other community is surrounded by multiple options to have nutritious food, fresh, nutritious food. And our last social determinant of health is social and community context. So this includes positive factors such as social integration, social cohesion, civic participation. Social and community context also describes or also incorporates more negative aspects of experience, which can be harmful to health, including discrimination, incarceration, particularly mass incarceration policies that negatively impact minority groups, unfair housing policies. And so we see in our communities, the ones with lower life expectancy have nearly 10 times the amount of adults over 18 that are incarcerated. So this can reflect some discriminatory mass incarceration, as well as this has a negative impact on this community because members are not in the community as consistently. If they are in prison, they're away from their families, they're away from those resources that they need to improve their own health and the health of their families. Additionally, incarceration is a big social determinant of health and risk factor for negative outcomes as well. People are not as healthy in that environment as they would have been in home. So we've talked about the 5 social determinants of health, and now we are going to review them in the context of the COVID-19 pandemic, which has been called the inequality virus. So during the pandemic, how much money you made was a stronger predictor of whether you would die of COVID-19 or whether you would die from natural causes or older age. And income inequality was only one of the many health inequities that increased during the pandemic and has continued to persist in our post-pandemic world. So between 2015 and 2018, there were great strides being made at reducing extreme poverty or a family living under $2.15 per day. However, in February 2020, the COVID-19 recession or the Great Lockdown began, and within 7 months, every advanced economy was in a recession. So we can see kind of this increase in poverty after this. So food insecurity significantly increased, extreme poverty increased, and we had racial, ethnic, and gender disparities in who was most at risk for these negative outcomes, with more minority groups at greater risk for loss of income, job loss, as well as lower abilities to work from home. So this was primarily due to disadvantaged groups being or holding lower wage positions that increased risk of COVID-19 infection and were not able to be worked from home. So our next social determinant of health, neighborhood and physical environment, were also very important, and not only risk of catching the virus, but also related to outcomes and quality of life during this time. So many environmental factors could increase risk of infection. So high density housing or many individuals within a small area made it very difficult to social distance. Additionally, homelessness. There were not opportunities to be able to shelter or to be able to be fully isolated and also receive needed resources in many cases. Additionally, air pollution and some of the other environmental factors, such as mold or poor quality of housing, do contribute to health conditions that would increase risk of COVID-19 infection, as well as produce worse outcomes. Additionally, if you're in an area that doesn't have many resources, so food deserts, not many healthcare providers, that resulted in needing to use more public transportation or needing to travel more to be able to access those resources, which then increased exposure to others, which could increase risk of infection. Additionally, less access to testing and screening meant that individuals might not know that they had COVID and potentially spread that, or not be able to receive the access to care they needed because they didn't have a diagnosis. Additionally, there were higher rates of risk factor for worse outcomes, such as asthma. In addition to kind of risk and infection in that direct one, the lockdown and being more socially isolated is more difficult in an area where there's very little access to green space, fewer bike pedestrian paths or outside park or safe community areas. This was a time where many people went outside to be able to escape their area for a bit, and not being able to have that built environment or that neighborhood where you could safely be outside negatively impacts mental health and quality of life. We also saw some pretty stark changes in education. So during the pandemic, the rates of learning poverty, or the number of children unable to read and understand a simple text by age 10, increased. So we see in lower middle income or developing countries, this increase from 60 to 77%. And then in higher income or in more developed countries, we also saw that this almost doubled from 8 to 14%. Additionally, a technology desert or a lack of reliable internet or computer equipment led to unequal access to education in many areas when schools were not being held in person. And in addition to a lack of academic resources or learning during school closures, schools also provide many services and resources that are very important, not related to academics, but important for healthcare, including meals, mental health services, as well as menstruation supplies. And then in the healthcare system, pre-pandemic, during the pandemic, and post-pandemic, there are racial and ethnic disparities in healthcare, as well as gender disparities. And we see that many groups are less likely to have adequate and affordable insurance, less access to healthcare providers, participating in underfunded or understaffed healthcare systems, and then having to wait longer, having to travel longer to an appointment, and having lower access to telehealth. And all of this together leads to less preventative care before. And we know how healthy you were going into the pandemic, how well your comorbid medical conditions were, has a direct impact when you later have an infection or stress or anything else. And there also are lower rates of accurate diagnoses if you're having less access to service and potentially lower quality of service. So together, this led to racial and ethnic disparities. So in the US, Blacks, Latinx, American Indian, Alaska Native, Asian, Native Hawaiian, and Pacific Islander, and other non-white racial groups had less access to COVID-19 testing, greater risk of infection, and more adverse outcomes. Additionally, there was inequity in post-infection specialty care. So there were racial and ethnic disparities in whether someone was discharged from the ICU to a skilled rehabilitation facility to be able to build on their recovery trajectory and receive essential services to help their recovery go as well as they could, versus individuals being discharged home with high levels of medical need, often in areas that did not have access to specialty services or had many of those healthcare deserts we discussed. So today we talked about social determinants of health, why they're important, examples of them, how they show up in our communities, and then also described how many of these contributed to inequities during the COVID-19 pandemic, and also how the pandemic changed some trajectories, including extreme poverty. So we had some increases after years of decline, which reflects that we still have work to be done in these areas. And the next part 2, we are going to be discussing social determinants of health and how they relate to neuropsychology specifically.